Well, good afternoon. I'm Dr. Leigh-Ann Webb, and I'd like to welcome you to the NNPA and Black Press Association's Tune In Live. Today, I'm really excited because we're going to talk to four of some very distinguished guests. We're all physicians. We're also all friends. And interestingly enough, we're also first-generation physicians, meaning we are the first physicians in our families. Some of us are also the first people to have a college degree in our families. So we have, since COVID-19 has started, we have actually been having conversations surrounding how COVID-19 has been impacting us, our families, and our communities from both the healthcare standpoint and a personal standpoint. We've been having these conversations constantly ongoing for weeks. The things that we have talked about have evolved, but the care and concern in terms of the disproportionate impact of COVID-19 on the Black community is still very much still present and a common thread. So let me introduce our guests and our friends. So today we're going to talk about the hopes and misinformation, the fear, sickness, and death as it relates to the impact of COVID-19 on our Black community. So here with us today, we have Dr. Taison Bell. Dr. Bell is an infectious disease and critical care physician at the University of Virginia, where he's the medical director of the intensive care unit and has been very instrumental in leading the institution's response to COVID-19 on a health systems level. We will be joined shortly, I hope, by Dr. Rashonda Mitchell, who is having a little bit of technical difficulty. There she is. Hi. We were just talking bad. We were just talking not bad. We were talking good about you. We're talking good about.
Sorry
so this is Dr. Rashonda Mitchell, who is an OBGYN physician and a nutritionist. She specializes in maternal fetal medicine. And what that means is that if you have complications of your pregnancy from both the woman's standpoint or the baby standpoint, you will go see Rashonda and she will take care of you. She also has a very keen interest in health disparities and the impact on pregnancies and has done a lot of research in that area. The next person that we have up is Dr. Cameron Webb that you see there. He is an internal medicine physician and a lawyer. He's also the director of health policy and equity at the University of Virginia School of Medicine and a congressional candidate for Virginia's 5th district, and also my husband of 11 years. So there's a connection there that you guys need to know about. So if I'm giving him a really hard time, just boot me from the conversation. And then last but not least is Dr. Ebony Hilton. She's an anesthesiologist and a critical care physician. She's also the co-founder and medical director of GoodStock Consulting, which is a consulting firm designed to address and find solutions to health disparities. In 2013, she actually made history as the first African-American female anesthesiologist since the MUSC's hospital opening. They opened in 1824, Ebony. So you're the first African-American female physician, but we are very lucky to have her with all of the rest of us at the University of Virginia now, and we hope she stays here for a long time. We're here with us in Charlottesville. So, we appreciate the Black Press Association for giving us this platform. Essentially, you have given us this platform. We've been having these conversations, but now we get to have it live and actually engage people with it. So it's very special. And we know that you all have been around for 193 years. So we are really standing on the shoulders of giants when it comes to reaching out to the community and speaking for Black voices, for and to Black voices in America. So you guys ready to get started?
Let's do it.
Go.
Okay, let's do it. So the first question is for Dr. Bell. I'm going to try to keep you guys, I'm going to try to call you by your professional titles. The first question is for Dr. Bell. So for our listeners who aren't involved in caring for COVID patients, give us a clinical picture. What does COVID-19 look like on the front lines? Who are you seeing and what are you able to actually do for them?
Sure. So thank you, Dr. Webb. And it's a pleasure for me to be with you all. And my role in providing care for patients with COVID is mainly in the intensive care unit. So I'm seeing the most critically ill of the patients who are in the hospital. And the themes that I'd like to get across are one, that COVID-19 is still a really serious problem. I think there's been a little bit of a change in the narrative around COVID, in that our peak we've seen our peak already. Our primary peaks are our new cases are going down. But it's important to remind people that people are still getting really ill from COVID, and in the ICU and in the hospital, we're still seeing a lot of cases. So despite the fact that some of our markers are getting better, we're still seeing a lot of people who are getting very sick. So in the ICU, a lot of times these patients are needing life support, more often in the form of a breathing machine or a mechanical ventilator that helps supply oxygen to the body, also helps remove carbon dioxide from the body. But in addition to that, some are even needing things like bypass machines if their lungs still aren't working that well. A bypass machine removes all the oxygen and puts oxygen in the blood and returns it to the body if the lungs can't work at all. And some people are needing dialysis as a form of life support as well. So people are getting really sick from this. In addition, we've talked about the spectrum of disease and which kinds of people will get serious disease and who do not. Fortunately, most people who contract do fine and have either mild or no symptom. This is 80% or 8 out of 10 people. But that does mean that there's a good portion of people who do get critically ill. And of those critically ill, there's an even distribution, meaning that I'm seeing older people, but also younger people. And when I say younger, I'm saying 20s, 30s, and 40s. Some of these people are relatively healthy before coming in and getting critically ill. So it's affecting everyone. Like many other places around the country, I am seeing a high proportion of African-American and Latinx patients. And that's been extremely disturbing and disheartening to see as well. So that's the second theme. And then the third is that treatment has been limited. We have remdesivir, which is an antiviral agent. My university, at the University of Virginia, was one of the study sites that looked at this drug. And it does improve outcomes, but it's not a game changer, so to speak. It doesn't ultimately reverse the course. People do get better symptom resolution by about 4 days, and there may be a trend towards improved mortality. But the real game changer is going to be a vaccine. And unfortunately, there's the thought that we might have something ready by the fall, late fall, or winter. But more realistically, it may be longer than that. So, the main message to get across that this is still a very serious disease, and you should, be careful and do things that Dr. Webb, Dr. Hilton will talk about later.
And when you are in the ICU, you said you disproportionately see people who are Black and brown, people's community of color who are affected. What does that mean for their families? Like, how has COVID-19 changed the way families get to interact with patients when they're in the hospital? Because for a lot of Black families, their support system is there, right? Their family that they're living at home with, people from afar, their church families. And we tend to rally around people who are sick. How has that changed with COVID-19?
Right. Well, one thing that's changed with COVID-19 is that a lot of hospitals around the country have changed their visitor policies, understandably, to decrease the risk of others contracting infection if visitors come into the hospital. But particularly for the ICU, where it is very important to have families involved, because sometimes patients can't speak for themselves or may not even be able to have a conversation or even open their eyes. It's very, very important that families are able to be present at the bedside. But one thing that we are seeing is that, unfortunately, because of multiple infections that can happen in households, even if we are relaxing some of those visiting policies, some of the other family members are infected with COVID, or they're so positive, even if they've gotten better, and they still can't come into the hospital. So that's been a big strain on being able to deliver effective care, because we're kind of relying on families to give us information. They can't be there with their loved one to share, the best information. We may be experts in the medical care, but your family is the expert in you, and they know exactly what you would want and what decisions you would make for yourself if you can't speak for yourself. So that's been a little bit of added strain to families, financial strain. Of course, it's always sad when someone's in the hospital, but that added layer of not being able to see families is another source of strain.
Now, Ebony, you are also a critical care physician in addition to an anesthesiologist. So you both work in the operating room as well as, upstairs taking care of some of the sickest patients in the hospital. But you've also done a lot of community work and a lot of advocacy work. And, we all take care of patients, but we're all also physician scientists. And that means we're kind of grounded in data. So Taison, Ebony, and Cameron, I know each of you have been heavily involved with the call for COVID-19 related racial and ethnic data data, including a call to the CDC and HHS for comprehensive race data when there were only somewhere between 300 and 400 deaths in the United States. Now we just passed the marker of 100,000 documented deaths, right? What does the data show, and why weren't we willing to release that from the start in the US? Ebony, you can take this first if you like.
Yeah, I mean, as you know, racial health disparities did not start or stop. It won't stop with COVID-19. And one of the things is, even before, I think I first started tweeting the CDC and the World Health Organization when we had 50 maybe deaths in the United States, maybe 100 deaths in the United States, to say, I know where this is going to go. We don't need data to show us that Black and brown people die at higher rates for any number of disease processes. So when you add on a pandemic, when you add on the influences of what makes and drives a pandemic, then we know that these targeted communities are going to be the most vulnerable. And so it wasn't until March the 22nd when BuzzFeed caught wind of those tweets that we had our first article that was published. And since then, we've had maybe like 10 to 12. And it still hasn't, even though we are voicing this is the problem I have, is that we're highlighting the problem, but there haven't been truly any tractions in creating the solutions, right? What we know is that from January, for every 2,000 Black people that were alive in January, one of them has died. What we know is that for every 3,000 Hispanic Americans that were alive in January, one of them has died and is not here with us now because of COVID-19. And the influence of that on America in totality, we see it's causing not only a health crisis, but also an economic crisis. Because our groups, these racial minorities, they make up the bulk of what we call the essential workers. So they are the grocery store workers. They are the people that's helping to keep literally our nation afloat while everyone else was staying at home, right? So how is this going to impact us for longevity's sake? And then another thing that we have to consider in this discussion is that we oftentimes mark and we talk about the mortality. And yes, 102,000 Americans are now gone. And that's an underestimate of what we actually know to be true. We haven't tested everyone who passed away. So the true numbers of how many Americans have died from COVID-19 is unknown. And we know that we are still on the cusp of this first wave, and we have a second and third wave potentially to contend with. So we know what that's going to lead to. But in addition to the mortality, we also have to think about the morbidity. And in those recovered cases that we keep reporting, that 80% of those closed cases are recovered. Those recovered cases include those who've had massive strokes, those who've had massive heart attacks and are now with heart failure, those who've had permanent kidney damage and are now dialysis dependent, those who've had permanent lung damage and are now oxygen dependent. And even when we're talking about our children, we're now hearing about this, post-inflammatory syndrome, right? Of where there's now over 100 cases in 14 different states of children that are having issues and complications with even the arteries and the blood supply that goes through their heart. And what does that do for the longevity of that child's life? So there's many factors that we have to look at of COVID-19, but ultimately, once we get a grasp on this virus, which may take a year or two at good times, but once we get our grasp on that, we have to deal with the fact of what led Black and brown and lower socioeconomic status communities to have the biggest impact. And we must address those social determinants of health before we move forward. It cannot be ignored for any generation to come.
Thank you, Ebony. And we will get into that. We'll ask Cameron a question about social determinants of health as well. But why does it matter to actually show the data? We saw this happening in China, and we saw this happening in Europe, and we saw this happening across the pond. And we knew it was coming, and we knew the effects that this would have on our communities from several thousands of miles away. Why is it so important to track this data in real time?
Well, I always say you can treat a symptom all you want. For instance, if someone comes in with chest pain and I just give them some narcotics to ease that pain, it could be that their chest pain was related to the fact they were stabbed. It could be their chest pain was related to the fact they had a heart attack. It can be related to the fact that they had a pneumonia or they were having a panic attack, right? All different types of disease processes that cause that same symptom. And this is the same thing with COVID-19. The mortality is the symptom related to, right? The end result of this COVID-19. But what's the underlying disease processes of the system that's leading to Black and brown people being sicker? And so you can't talk about these comorbidities that we associated with a higher incidence of mortality. Comorbidities means past medical history, if you have certain disease processes. But you can't talk about respiratory diseases, for instance, like asthma and chronic bronchitis, without talking about the influence of industries being placed in certain zip codes and not another, and the systemic racism that associates with the districting of different neighborhoods, right? You can't talk about hypertension, diabetes, and obesity without talking about natural food eateries and food deserts and food apartheids that I'm sure Dr. Mitchell will talk about, being a registered dietitian. I mean, you can't talk about even simple things that we're not considering when we're saying the vulnerable populations of prisons, for instance. You can't talk about that without talking about the systemic racism that leads to higher levels of Black and brown people being imprisoned and the policing of our neighborhoods. So all these social determinants of health and all these factors that feed into what is now deemed the vulnerable population, we must address in America before moving forward, because this pandemic was different in that in the other racial health disparities, they only impact the community that it holds, right? If we have higher cancer rates, it's only our family that dies. If we have higher maternal morbidity, it's only our family that dies. But this one, when you're not treating the Black and brown communities and those who from lower socioeconomic status communities, when they go back to work as the essential workers and they carry this disease out of their community, the entire nation will get infected. And that's what we're seeing. When we see the collapse of the economy, when we see these rates that's just jumping, it's because we allowed this virus to fester in a breeding house of the Black and brown neighborhoods.
I'll allow Cameron to piggyback on that. Can you talk more about why COVID-19 is ravaging the Black community? One of the things that you do is you run a lab and you all research the social determinants of health, and out of that hope to get actionable data so that you can inform health policy. What do we need to know as community members, as listeners, about all of the reasons why this is sort of ravaging our community?
Yeah, well, I think it's a few things. So first off, it's been said quite often that when America gets sick, Black people get the flu. That's kind of an old statement. And I think when it comes to COVID, when America gets the coronavirus, Black people are dying. And there are a lot of reasons why. They're historical. And there's a one-word answer, and it really comes back to racism. That's the underlying reason why we're seeing the disparities that we're seeing. And that racism, it manifests in a lot of different ways in our society. So that, you use the term social determinants of health. And that's an area where I do work, but often I describe it as just the health-related social factors. Health doesn't happen in hospitals or in clinics. It happens in our communities, and that's actually where your health is determined. So it's where you're born, grow, live, learn, eat, play, and pray. Those are the spaces that shape and determine your health outcomes. And so as Dr. Hilton mentioned, that's going to shape and determine your likelihood of having certain conditions like diabetes or high blood pressure or even cancer that may increase your risk of having the outcome of death with regard to COVID. So that's part of why, right? We know that racism shapes our communities shape our health outcomes, and that's important to note. There are 5 different domains of those so-called social determinants of health that I like to talk about. And so just quickly, we can talk about how each of those are the social determinants of COVID, right? And then the first is economic stability, and that's things like income inequality or food insecurity, so not having access to the foods that folks need, or even housing instability. And we know that all of those impact, your outcomes with regard to COVID, because as Dr. Hilton mentioned, a lot of our essential workers, the people who don't have the privilege of being able to work from their basement or from their den or their office, are the individuals who are in the Black and brown community. So disproportionately, because of economic considerations, those are the folks who still have to go out into this environment every single day that has a lot of this virus, and they're putting themselves at risk each and every day, particularly when we don't have adequate personal protective equipment or PPE. When I mention housing, that's an important one because, again, I'm telling you that this all stems from racism. And the housing one is particularly interesting because of this notion of redlining, how historically we would design communities to keep the Black population in certain spaces and to put other people in other spaces. But then when you couple with that things like exclusionary zoning, which means that you can't even move certain types of housing units into certain parts of the community, what happens is that our Black communities are kind of compressed in certain spaces. And those are the spaces where a virus that spreads pretty quickly from person to person in an environment with everybody where you have a lot more essential workers, a lot more folks who are out working in the community, it just leads to more spread. And so you can see how in cities like Chicago or in New York City and lots of places where you have that population density, you can see how that comes together to cause more spread of disease. And you couple that with the burden of chronic illness, and you just see more death with that. So that's educational stability. The education space is critical because that includes kind of educational attainment, so how far you go in school, but that also shapes what jobs you're able to have access to. So again, it's who has access to that privilege of being able to stay at home. In the healthcare space, it's health access. Who has access to a primary care provider so they can get the test for COVID, or who has, we use the term health literacy. This is a complicated, virus. There's a lot of information coming at people very quickly, but our ability to spread the good information. So we're not telling folks like our president did that they need to, drink bleach or whatever it was that he said, right? We need to give good information. We need to make sure that folks know where they can get that good information. So, Dr. Hilton and Dr. Webb, you all both work to really get that information out into our community here locally with your Staying Alive flyer. And hopefully we'll be able to show that at some point. Getting good information into the hand of the community is going to be critical. In the absence of that, you're going to have more spread and you're going to have more death. And so, the neighborhood and built environment is the fourth. And, again, housing quality, that has a huge impact. And then finally, it's, the social and community context. And that's where discrimination comes into effect. That's where things like our criminal justice system come into effect. And, Dr. Hilton referenced it, but just down the road from us here, we have a prison that had 142 inmates who tested positive. At this point in the Commonwealth of Virginia, about 10% of the inmates are Black or brown, actually are African American, or are COVID positive rather. And disproportionately, those are African American because we have a criminal justice system that disproportionately criminalizes Black men, puts them in jail for long periods of time, and now they're put into a space that increases their likelihood of getting COVID and ultimately dying. And so, again, all of these factors come together together, create a really unique situation for Black and brown communities. And I think that, again, the punchline here is it's all rooted in racism, and our work has to be to undo that racism so that we have communities that are designed for people's health.
I want to touch on something you said about misinformation. There was a lot of misinformation at the very beginning of this pandemic, particularly as it relates to the Black community. People were saying that we couldn't get it. Do you think that's still an issue now, several months in, several weeks later? Are you finding that that's still an issue when you go out to talk to the community and to your patients?
Yeah, I think it's a little different now, but it's still a problem. There's still a huge problem with misinformation. You remember Waka Flocka Flame had that famous interview when he was like, Black people aren't getting it, right? And then early on, you remember on Twitter and other social media spaces, people were literally kind of discrediting as some Black people started to get infected. They were like, yeah, but they're mixed, or yeah, but the reality is now you're not hearing that narrative just the same, but there's still the young people can't get it necessarily, or the actions that I'm taking aren't going to put me at risk. People don't have adequate information on what puts them at risk. And the fact of the matter is everything puts you at risk. Just being out in our community, being out in spaces, you have to take an abundance of caution in order to stay safe in this pandemic. And just yesterday, I was in the community just leaving the hospital, and I saw a group of 10 individuals with masks around their chin taking a picture together. Right? That just tells me how much that information is not penetrated. So we have to continue to get good information out. This is in the setting of a whole movement of anti-maskers, folks saying these masks aren't important. Right. Here in Virginia, our governor saying everybody needs to wear a mask. So we're in for a fight. This is falling along cultural and political lines, but it's our job as the physicians, as the individuals who know to respect the science, to lean in and get good information to people.
And it seems like Dr. Mitchell, I'm sorry, and I also got called out for not saying Dr. Webb, Dr. Cameron Webb, so I'm going to say that now. Thank you very much, Dr. Webb, aka Hubby. So Dr. Rashonda Mitchell, it seems like there's not a lot of information about how this COVID-19, how this pandemic is affecting pregnant women. Can you give us some insight into the effect on people who are pregnant and what it looks like to provide equitable care for that patient population?
Yes, of course. So I care for high risk pregnant women with high risk pregnancies. I'm generally trained as a general OBGYN and then care for women who are at higher risk. And the reason right now, so we're a special population within a special population. And so the reason why we don't have as much information now, we've been in this pandemic for about 3 months. Pregnancy, I guess all of pregnancy takes about 40 weeks. So a lot of the outcomes of the effect of this virus on pregnancy, we're not going to see right away, right now. We have started to see some trends of a couple of things. So right now we don't have quite the data or the outcomes of what this virus is doing to pregnant women. However, there was some initial thought that pregnant women were at a greater risk of getting the virus. They're not at a greater risk. However, if they do get sick, it's not a good thing to have a pregnant woman whose respiratory reserve is a little bit different. If she is gravid, her uterus is large, to get this condition. So right now we don't have a lot of data. But some of the things that we are starting to see is we are looking at preterm labor. That's if you have your baby early, you go into labor early. And then also we look at some second trimester losses or abortions, we would call them, that are happening. Those are things and trends that we are currently looking at, but we just don't have enough data to really say with some type of validity of the effects of the virus.
And when you say abortions, do you mean like someone going out and getting an abortion in the midst of COVID-19? What do you mean when you say that?
When I say abortions in the world of obstetrics, we just mean a loss of pregnancy. And now whether that happens electively, which means someone chooses to have one, versus spontaneous, which means it happens, what people would say a miscarriage. It just depends. And I will say overall, this virus has had a bigger impact on women's health overall, because access to specific treatments such as abortion may have been limited in some states because elective procedures were stopped. And that could be, a woman could have that right to choose to discontinue a pregnancy because it may mean that it's a detriment to her life, or that the quality of the life of the fetus, if it's, for an example, an anencephaly, which means that it doesn't have a head, that there's no point. They may choose to have a elective abortion, but if their state is limiting all elective procedures, they may not have the opportunity to discontinue discontinue that pregnancy. So we will say that more right now, what we're seeing as far as pregnancy, some of the effects are really more policy related. And one example would be the visitation policy that Dr. Bell discussed earlier. Normally, when a woman is pregnant, you have a lot of family support. People want to be around to support this woman when she goes into labor. However, on labor and delivery right now, to limit exposure to the virus, some places in high density populations are not allowing women to have a support person with them, whether that's their spouse, significant other, family member. And then in some places here, I know at UVA, we limit it to one. You are allowed one person to be your support person while you're in labor, and they cannot leave the hospital the entire time you are there. That way we're limiting exposure for our staff, as well as other women and babies in the hospital. So right now, I think for pregnancy. It's more about, as Dr. Cameron Webb discussed, it's about the social determinants of health for women. Like women are limited in their support system. They're limited in some of the access of care. And also when a woman has a baby, if she is a person under investigation, her baby may be separated from her during that time, which can affect breastfeeding and bonding for mom as well. So, I would encourage moms to really have a nice discussion if you're pregnant with your healthcare provider about your plans for delivery and who's allowed in the labor and delivery room, and making sure that you have someone there that can advocate for you, because we know that Black and brown women have a higher morbidity and mortality when it comes to pregnancy, and that's regardless of your financial or economic status already. So this is definitely an uphill battle, and we really have to focus on maybe just advocating right now in the midst of this virus for our pregnant women.
Now, you shared your story before about advocating for pregnant women, which is what you do as part of your personal, your professional life. You shared your story when you were pregnant on a radio podcast about how you talked to your husband about advocating for you if something were to happen and you were not able to speak for yourself. I was there when you had your baby a few months ago, and I know you shared this story as well, but you needed an advocate, and you're a successful female physician with a professional husband and everything else, and you still needed an advocate. So what are the tips that you have for listeners who may be in that same position where someone's going into the hospital and they now have no one to advocate for them?
Well, one, I think you need to at least be informed and have an established plan before you go in. Whether that be written or you have someone, your provider knows what you desire as in during the labor course. I would also put it in writing if you need to. People do have delivery plans when they come in, and hopefully if you are allowed that one person to advocate for you, make sure you have that discussion with them, because it is a serious thing. I, for one, know, and it was completely, I will say, unexpected, because I had a normal pregnancy. It was the actual delivery process, and we can get into the whole conversation of biases that we see in healthcare, and how that affects someone's ability to advocate for you or for yourself. And so those were the biggest things that I was concerned for. So I would always tell people, have someone that can advocate for you and your life, because it matters, and have a plan and be informed. My first bit of advice is be informed, communicate with your healthcare provider, and have an advocate, whether that be something in writing or have a person with you that can advocate on your behalf in case something happens.
Okay, thank you. We're going to pivot a little bit to talk about testing. And I guess that does kind of dovetail nicely into advocacy, because I would consider all of us on this panel, and I guess myself as the moderator, as physician advocates for our community. So I guess this question really goes towards Cameron, Dr. Cameron Webb, and Dr. Hilton as well. One thing we continue to hear over and over again, that there's not enough testing being done across the country, period, and certainly not in communities of color. And I know you all were recently heavily involved in the planning of community-based testing here in Charlottesville. What are some of the ways we can address the lack of access to testing, and how have you all approached the testing capacity issue?
Well, I can start from the standpoint of how we did it here in Charlottesville, and it started with community leadership. So it was a former city Dr. Bellamy, who said, hey, we need to get testing into communities of color. We had some neighborhoods in particular that had that combination of social determinants of COVID that I just talked about a little earlier. And he really wanted to focus in on those, brought together the mayor, the other hospital system, Sentara Martha Jefferson, that's here in the district, and just putting those things together, bringing the health department, bringing other kind of social justice organizations. We had a team of individuals, and then we said, well, where do we test and how do we test? And so we put together 2 sites. I mean, the truth of the matter is it had to be led by the community. It had to be individuals kind of speaking up and saying, this is what we need in our community. So I think the first thing to say there is that it's so important that you use your voices in your community to say, this is what we need. The testing capacity has ramped up around the country to some extent. And so now it's a matter of being that squeaky wheel that says, we need the resources right here. And the testing that we built out, of course, we were able to test over 300 individuals between our 2 sites in one, early afternoon. So it was great. And actually, Dr. Hilton was one of our testers. So maybe you can talk a little bit more about that experience, Dr. Hilton.
Yeah, I saw a great picture of you testing someone.
Was it testing your husband? Because
no, it was testing Dr. Wes Bellamy.
Right. Yeah. So, with GoodStock Consulting, so I have a medical consulting firm that we co-founded with my 2 business partners, Kimberly Butler Willis and Kelly McKenzie. But one of the things that we're pushing now, we actually were contracted by the Virginia Department of Health to address this issue of testing and testing equity. And one of the questions that we're pushing now is not only are we testing, but what tests are being deployed. I think we have to be very clear on this podcast or this messaging, that we know that tests are not 100% sensitive. And what does sensitive mean? Sensitive means that when you take this test, that if you get a result that you can truly firmly believe that if it says that you are negative, that you truly are negative. What we're seeing with these COVID-19 tests that we have available is that there's a high percentage of false negatives, meaning that when you get tested, even if you're infected with the coronavirus, it may still come back saying that you are absolutely clean. And so we know that different types of tests have different sensitivities associated with them. And so our push of the state is to say, well, which tests are we using for our different population groups? Are they consistent across the state? Or is it which tests are being deployed to the Black and Brown communities? Which tests are being used in the lower socioeconomic status communities? When we're having these hot spots, are we getting the best tests available to go to that region to truly tell people that if they test negative, it's the best version of tests that we have available? Because not all tests are being created equally. So yes, I think it definitely does have to come from a community-led initiative. And I do think people need to be advocates for themselves. But honestly, I put that responsibility on the medical team, the medical system, the doctors, the nurses, the people that are actually educated in this arena. I don't know anything about cars. I don't want to be an advocate for my car. If I take it to the dealership, I want it to be fixed, right? And the same thing should happen with our health. We shouldn't put the responsibility and the weight of that on people more than what should be required. So yes, each individual needs to know how their body functions, but each individual shouldn't be an expert in the sensitivity and specificity of a COVID-19 test versus a influenza test, for instance, right? So so that being the case, with that great amount of power that we give to the medical system and to the state, with that much money and influence that it has, then we need to hold it accountable and saying, then make sure those resources are distributed through an equity lens. And and when we see that stuff is falling through the cracks, to speak up on it. And I think that's what we're doing here on this panel today.
Right. And Taison, Dr. Bell, you've been leading the charge in terms of at University of Virginia with both the organization and the innovation of our response at University of Virginia, but also you're working on identifying drugs that can effectively treat, or we hope can effectively treat COVID-19. At the same time, we know that there's a legacy of mistrust amongst the Black community and interacting with the healthcare system. How does this factor into your ability to see how treatments may work in different populations?
Well, good question. I think one of the first things to put out is that treating a patient depends on a therapeutic doctor and patient relationship, or relationship with the nurse and the physician. And what a lot of people don't understand, especially if you're not Black, is that mistrust in the Black community it's earned mistrust. There's a legacy of using Black and brown bodies for in illegal purposes to put forth the mission of the medical community. Going back to the antebellum period after the Civil War, where grave diggers would come and dig up Black bodies and use them for experiments in learning anatomy in medical schools. We've heard about Tuskegee, where hundreds of Black men who had syphilis were followed over time, studying the natural history of the disease course without their consent, not telling them about their diagnosis, not giving them treatment, even though there was effective treatment. Henrietta Lacks at Johns Hopkins, who had her body cells that were stolen and used for medical research, and now 10,000 patents are used off of that technology, with family receiving no compensation for that. So these stories have propagated over time. Black patients know about these, and there's a natural mistrust of the medical establishment. And so if you don't understand that you're already starting from the back foot, that you've already earned the mistrust and you need to earn that back, then it's hard to force that therapeutic relationship. So it is important that when we're trying to study drugs and new therapies, that we have a diverse representation from all segments of the population, so that we understand that if something works, we can say that it works in everyone and not just a limited population. So we do want to have good representation from Black patients in our clinical trials. The one that we talked about earlier, the remdesivir, we ended up having about 20% representation from Black patients, which was good, but we had to earn that and step up and make sure that we were explaining ourselves, that we were giving patients good information, and that first and foremost, we were looking out for their needs. Fundamentally, what it's all about is trust between the physician and the patient. And as a physician, it's my job to earn that trust. So as a patient, I expect patients to hold me accountable. And if you're asking questions, and if you want to make sure that you have good information, you're doing your job as protecting your body. And it's our job to make sure we get that information to you. We want to be treated as human beings, because historically, the Black community understands that our policies and our cultural norms have devalued Black bodies. And so as medical professionals, we need to make sure that we're meeting that need and giving people the right information that they need to move forward and make a decision about their bodies.
Right. And we can and we do talk about this all day long, but I do want to leave some time for questions. And so do we have any questions?
I saw one question mentioning about the impact of spread amongst in church if you're on a choir.
Yes.
And they say that, Dr. Bell's wife is a professional opera singer. So maybe he could actually speak on that.
Sure. So, and this question's come up. My own parents go to a church that was considering reopening in the Boston area. And if you've been to a Black church, you know that we celebrate and we yell and we scream and we give praise to the Almighty. What that means, however, is if you're in a choir or if you're singing in the pew, that the normal sort of the way that COVID spreads is even enhanced, because it spreads through droplets. And droplets that leave your mouth or your nose can infect someone else by getting on them. And when you're projecting your voice and screaming, you're exhaling more forcefully, and more of those particles are spreading out to the atmosphere and through the church. And so there was a study that demonstrated that just one person who had coronavirus and was in a choir, they infected 87%. So 87 out of 100 people that were close to them who were also in that choir, and they weren't all, socially distanced, but people who were even outside that 6 feet window or that 6 feet distance, they got infected too. So it's something that we do need to be extremely careful about as we reopen, that we're following best practices, and certain things that increase the risk, like sitting in an enclosed space, sitting next to air conditioning, things like that. We need to be careful about how we go about going back to the normal things we do.
And this question would be for everyone. What suggestions does the panel recommend for getting more of a boots on the ground approach to disseminating accurate COVID information to the communities of color? This is a great question because Ebony and I have done a lot of community outreach and we struggled with how to get it out there, right? Do we go door to door? Do we just do this, by email access? Do the people who don't have social media, are they getting the information? What are your sort of tips for people who want to help disseminate good, factual, accurate information to our communities?
Well, for me, I think you don't fix a wheel that's not broken. So use the systems that's already in place. The first thing we did was contact all the lead pastors of churches, right? We know that people call in to the pastor for the sick and shut in the Black and brown community. So we know that they would already know a certain subset of if their church family were showing signs and symptoms of COVID, that they would already know how to direct us to them. But also we knew that the community already trusts them. And so they would be trusted to give them information that they could actually believe in. So we contacted the community leaders. And now what we're working on is actually an initiative with things that are not as in vogue, like wearing masks. Some people just don't like to wear them. They don't think it looks aesthetically pleasing and it's not the most comfortable. But one of the things we're looking into now is to say, how can we make kids actually think this is cool, right? So what if we engage the high school, the local high schools to say, put your mascot on these masks? And we know that there's a rivalry with football games and basketball games. So if students and kids can start to represent their schools with use of this mask, that might be a way to normalize this, because for better or worse, COVID is going to be with us. And it's going to be with us tomorrow and the next day and the next day. And we are looking at this in the medical field of more of a marathon than a sprint. So we may be still talking about these same things come spring of next year, because medicine is not as smart as this virus. Biology will always win. We try to mimic what the body was naturally designed to do, but we can't get close to that perfection. And so that being the case, use the systems that we know work. And the best commodity we have literally is human capital. So speaking to those influencers within the communities, going door to door, if that's what it takes, then that's what we'll do. But that's what I can say about this entire panel here, is that we don't get tired. If there is an event to be planned, we're going to plan it. If there's an event to show up for, we're going to show up. So that's why, again, we're very grateful for the Black press for giving us this platform to truly talk to people, to say that if it's your time that you have to donate your time. If it's your talent, you have to donate your talent. If it's money that you can donate your money. But there is something in each of us that we do have to give back to the community to make us all better.
Good. We have another question here. Oh, sorry.
No, I was just going to add to what Dr. Hilton said, is that we have to be our own heroes at this point. And I want to encourage people to, one, if you're looking for information, go to trusted resources. So your resources need to be websites or people who have been validated and verified. And the way you can do this is most of the information you are looking at, if you look at it on the internet and it ends in the website ends in .org or .edu, usually that information is validated. .com is not always the best information. If people are looking online when you're searching for things related to COVID, that would be the first thing if you're going to look yourself. The second thing is, of course, I provide women's health care. I think women are a great motivator in our households, and we are the ones who help take care of our households. So reaching out to the women in our community, whether that's sororities, whether that's church members, households, we need to filter this education to them. Then it trickles down to children, it trickles down to husbands, it trickles down to uncles, aunts, and everyone else. So I would be a very big advocate for mobilizing and utilizing women as an area, because also we're big consumers. So we buy specific things. Mothers are buying these masks and making sure the house is taken care of. And not saying that fathers don't either, but that would be a good, if we're trying to find a place to have the biggest impact, these are the areas we need to look at.
My favorite saying, Dr. Mitchell, is women birth nations, so of course we can run one. So I agree with you.
Yes. Absolutely.
Right.
So we have another question from Patrick here. What should people in certain at-risk community or at-risk groups like kidney disease, diabetes, hypertension, obesity, cardiovascular disease, what should they be aware of when it comes to COVID-19 related clinical trials? Because as we talk about these treatments and we talk about the vaccines, like I want our people to get vaccines. Like I think I've heard arguments against like getting the flu vaccine and getting the pneumonia vaccine. And these are people in my family and people that I know, and they're professionals and they have high health literacy. And not to say all of those things means you should get a vaccine, but we have evidence for a lot of these things, and yet they still don't want to take a vaccine because of the mistrust in their community. Anyone want to tackle that one? That's a big question.
Sure. So I can talk a little bit about that. So I would separate out a little bit drugs and therapies for people who have COVID, and specifically vaccines and the trials to develop them. So as far as people who have chronic conditions, and Dr. Webb mentioned them, so kidney disease, diabetes, hypertension, obesity, these are some of the conditions that do make you more at risk for having worse outcomes when you have COVID. So we've seen that people who have these underlying conditions will more likely do worse. So that means effectively in the community, you should be more cautious about doing things like going into enclosed spaces. If you have someone else in the household who could go out and get groceries and supplies who's healthier, you should have them do that. But when it comes to clinical trials, there are different inclusion and exclusion criteria. We want to make sure that the drugs aren't harmful. So it all will depend on what the trial is looking at and the patient population that they're explaining. So your physician, your treatment team should provide you with that information about the trials that they have that they are offering, what those inclusion and exclusion criteria are, to see if you could qualify for a trial. When it comes to vaccines, this is a little bit different, because instead of offering a treatment to someone who's already really sick, we're now trying to prevent disease in someone who's very, very healthy. So those early vaccine trials are going to look at specifically healthy people to see if they generate an immune response. The reason that you look at healthy people is because they don't have chronic conditions, they have healthy immune systems. If they don't mount a response to your vaccine, then nobody else will. So it's not worth starting off looking at the broad population, because you want to make sure that the vaccine actually will generate some of those protective antibodies. And then as your vaccine trials go on, you test more and more people, and then you include people who have chronic conditions, people that are older, people who may not have developed the most effective immune response, and then you see if the vaccine still works in those populations. So get the information that you need from your providers, and you can see if you can qualify for some of these trials.
In response to sort of this disproportionate impact of COVID-19 on communities of color, Chicago Mayor Lori Lightfoot said, "This is a call to action moment for all of us." However, I know there are a lot of people who will be watching, or who are watching right now, who think of themselves as advocates, and some who have no idea how to drive the change that we seek in our communities. It's sort of a mixed bag. And honestly, it can be mentally exhausting. Moving forward, what does a call to action look like for each of you? And what do you think the NNPA Coronavirus Task Force can do in messaging Black America about the impact that we can have on coronavirus, or fighting coronavirus?
Well, I think we can answer part of that question with another one of the prompts. I see L. Martin Johnson Pratt talks about misinformation and messages about not wearing masks coming from trusted sources. I think the Black media has a unique opportunity here to really be a purveyor of good information, to lean into that idea of, hey, we've vetted these sources. This is something that we can trust. And I think that that's such a critical role. It's the way that we've always looked to the Black media. If you look even historically, we've always looked to it to give us the real truth, the real information. And I think that that's needed now as much as ever. So I think that that's one of the roles the NNPA Coronavirus Task Force can play. And as far as people's advocacy, I think everybody, I think Dr. Hilton kind of laid it out. Your time, your treasure, your talent, whatever it is that you have to offer to this, understand that our communities are hurting all over this country. And I think it's just critical to find out how you can help out. And sometimes that's supporting a local food bank. Sometimes that's just calling and checking in on a loved one, because, the impact of this isn't just on folks who are infected. The folks who are shut in and have no access to other individuals, that can be devastating from a mental health standpoint. So making sure that we are our brother's keepers all throughout this pandemic is going to be one of the keys. And I hope that I think together we're going to get through this effectively.
I think I kind of echo that same sentiment as far as I think sometimes people get overwhelmed when they think about being an advocate, that it causes paralysis. And so you don't have to be an advocate on the federal level. You don't have to be an advocate even on the state level. You can literally be an advocate just in your own home. And what do I mean by that? Holding your family members accountable, and not only accountable, I think that's a harsh word, because I do know it's been a few months now of life being completely different. So I know you do get burned out, and there is a desire and a need to have socialization. But reminding your family that we all want to see each other this Christmas. And again, there's 102,000 families that are forever changed, that they brought in the new year together, and they won't even get to see, the 4th of July this year. And it's tremendous. And the swiftness that COVID-19 has really kind of uprooted us in our normalcy. So I think if you get overwhelmed of, well, what can I do? Literally start in your home and saying, for me and mine, as for us, we will praise the Lord and we will wear our mask. It's one of those things, right? Hallelujah. But seriously, as for me and mine, we will do these certain things to make sure that at the end of the day, I don't want to wake up knowing that I didn't do enough or I didn't say enough. And when you're going to families, I know one of my family members, they had a baby shower the other weekend, and I about lost it when I saw it on Facebook. I'm not gonna lie, because I didn't see anyone with a mask. And so I had to call each and every person that I saw in the video to say, what are we doing? Now I'm a day or two late because I was actually doing COVID-19 testing on Saturday when this was happening 2 states away. But it still doesn't stop me from saying, when I see it, call it out, because ultimately, I'd rather you be mad at me than to have to not even be able to bury you because we're still in COVID, where we can't even gather to say our last goodbyes. And this is a reality that we must face. This is not a game. It's not something to take lightly or to joke about. It's not about being cute, right? The way we see life now, it has to change, and hopefully this too shall pass. And I know I'm getting really preachy, but hopefully this too shall pass, but we'll live long enough to see it pass. And so be an advocate where you are in your space, real time, call people out, and do it out of a place of love and not anger that we're seeing on some of the videos. So I think that can be kind of counterproductive. But at the same time, don't allow someone else uncomfortable state of wearing a mask cost you your life. You do what you have to do to protect yours.
That's great. So we have about 3 minutes left here, but I'm sure we'll finish this conversation offline in our group chat.
Right.
I personally really enjoyed this. I think the more conversations about this, the better. I think this pandemic is really reminding people of how much we have at stake in the Black community within this pandemic. And it's also really highlighted the issues for us as a crisis within a crisis. Is really unsettling. And it really forces everyone to think about the fundamental roots of inequality in our country and also in our healthcare system. What are your parting words for our audience? And we're all a little long-winded. We have about 2 minutes left, so you have a few seconds. Go.
Okay. He's muted.
Thank you. I'll keep it short. Intensive care doctor. So I love the statement from Dr. Mitchell that we are our own heroes. progress requires pressure. And all the progress that's been made in the Black community, it comes from ordinary people who are doing extraordinary things. My own personal hero is my mom, who's a service worker. She works at Target at the checkout line. She's exposing herself and coming into contact with many people. Part of the role that she does is serving her community, but she also spreads the word about accurate information. She went in and got her oil change a couple of days ago and just talked to some of the service workers there and said, hey, can you check out some of these links about getting some accurate information about coronavirus? Information is our weapon here. And the fact that she's spreading information, serving on the front lines, that's why she's my hero.
I just want to say, for me, this is an opportunity for us to really take a look at health literacy in our community, which I think is so important and so empowering. The more you know, the more you grow. And I think this is an opportunity for us to use technology like Facebook now and use it as a tool to provide information and help educate people of color. And so I really think this is a great opportunity, and that I hope that the NNPA coronavirus task force uses this opportunity to help as I guess elevate the platform for health literacy, which is a big component for me. It's very important.
Yeah, well, I would just add that 102,000 people shouldn't have died from this virus. Black people shouldn't be dying more. Our Latinx brothers and sisters shouldn't be contracting this virus more. None of those things should be the case. And the truth of the matter is, this is one of those moments where we have to make, as Representative John Lewis calls it, make some good trouble, right? Use your voice, be loud, and speak up. Because I think without speaking up, in moments like these, we die. And then this is just a critical moment for us as a community, for us as a society, and for us to show the strength that has absolutely typified Black people in the United States since we were brought here by slave ships 400 years ago. It's that we always persevere through these moments. So speak up, be loud, agitate, and we'll be our own heroes, as Dr. Mitchell said.
I agree. I think Black people, Black and brown, we've not only survived, but we thrived during times that should have killed us before. We will never be the same. I don't like the phrase, "Oh, we'll get through this." We'll get through this, but it won't be the same. We know that. What I'm hoping is that with COVID, we will change everything that is a disparity to us, and whether that's the 1 in 5 children that don't have Wi-Fi connection at home, that weren't getting school teachings during this pandemic, whether that's the essential workers that are being forced to work, the undocumented immigrants that are not getting the quality of care. We need to collectively combine our voices with our allies and our racial minorities alike and say, these things that have been, they shall be no more. So again, find your voice, trust your voice, and be active in any way that you possibly can.
You heard it here, folks. We only ran over about 2 minutes. We hope that the Black Press America will have us back. So they've been the voice of Black America for 193 years, and we appreciate them having us on the show. We hope that we could come back. Hopefully, we didn't go too far over. And you know what? At the end of the day, we love us. We've been having these conversations for months, literally, and we will continue to have these conversations. So join us, find us on social media, send our emails through the University of Virginia Health System. You can Google us. Let us know what you want to talk about, and we can continue to have these very important conversations offline, on and offline. So with that, we'll all say goodbye and thank you. We'll see you next time.
Bye, everyone.
Bye.
Bye.